with EV and pembrolizumab being probably one of the main regimens that should be used now in the frontline setting. It's now approved in the US and in Europe. The second line space is a big open question. There's really no standard of care in that setting just because we really haven't generated that data yet. There are certainly several options available. The main option for most patients probably will be platinum-based regimens. So the regimens that patients would have gotten up front as the first-line regimen previously, before the advent of pembrolizumab, they will now be getting in the second line. So that includes Carboplatin and Gemcitabine, or for patients who are still eligible for Cisplatin and Gemcitabine as well. Other options, certainly for FGFR or patients with FGFR alterations, especially FGFR3 alterations, Urothelial will be an option, as well as potentially other FGFR inhibitors, and that's a space where potentially even a drug like Vedotin in combination with, let's say, pembro can be explored, and there are other options as well, including Sacituzumab Govitecan, which has a non-randomized trial data supporting its use in that setting, in a treatment refractory setting, but of course does have a recent phase 3 trial that was negative. We haven't seen the results of that trial yet, but for now, Trastuzumab Govitecan is also an option in the treatment refractory space. And then for patients with high HER2 expression, Trastuzumab Deruxtecan is an option and is now approved for patients that with actually very high HER2 expression, so IHC 3+. But importantly, again, I think this second line space post EV pembrolizumab is really a space that's ripe for clinical trials and further development, and that's where I think multiple trials will be considered there, but that's where, again, a combination like Vedotin and pembrolizumab, like what was explored in this phase 2 study, can be considered also.